Welcome to our participants today. I see people are trickling into our Zoom, so we'll get started here in just a minute. More slowly. All right. Well, as people continue to trickle in, we will get started here. Welcome to the Hennepin-University Partnership Summer Webinar Series. My name is Sarah Sandgren. I am a graduate assistant with the HUP, here with HUP Director Kathy Doty and colleague Scott Vargo, and our presenters who we're excited to introduce in just a moment. Thanks for joining us virtually today. A few Zoom reminders: your video and audio are not enabled, but please use the chat function if you need any support from the HUP team. And if you'd like to ask a question, you can submit them either via the chat or through the Q&A function. Those buttons you'll find along the bottom of your Zoom window. We'll monitor questions throughout, and our speakers will address those at the end. This webinar will also be recorded and available to you online after today. Look for an email from hup@umn.edu tomorrow morning with a survey link, a link to the recorded webinar video, and contact information. We hope you'll have a chance to give us a little bit of feedback. We are very excited to welcome our presenters from the University of Minnesota School of Public Health today. Kumi Smith is Assistant Professor in the Division of Epidemiology and Community Health at the School of Public Health. She studies HIV and STI epidemiology and is interested in infectious disease dynamics, social determinants of health, and health equity. She is also the director of the HIV/STI Intervention and Prevention Studies program at the University of Minnesota. Professor Smith holds a PhD in epidemiology from the University of North Carolina at Chapel Hill. Eva Enns is Associate Professor in the Division of Health Policy and Management at the School of Public Health. She develops mathematical models of the spread of infectious diseases that help evaluate strategies aimed at mitigating disease impact through prevention and/or treatment. She aims to inform better prevention, management, and control policies, as well as develop new methodologies or tools to better address issues surrounding infectious disease outbreaks. Professor Enns holds a PhD in electrical engineering from Stanford University. Today, they will present about mathematical modeling of the COVID-19 epidemic in Minnesota. We're so glad to welcome them, and I'll turn it over to our speakers.
Thank you so much, Sarah. So I'm going to start here. So I am Professor Enns from the Health Policy and Management in the School of Public Health. And I want to thank all of you for coming today, and also thank you for your service, because I know you are working to keep our county services running, and we really appreciate your adaptability and flexibility and commitment to the residents of Hennepin County and all the work you do. So thank you. As we get started here, I just want to acknowledge our collaborators. We have a long list of names and a large team at the University of Minnesota who've been involved at various points in the evolution of this project, and also our collaborators at the Minnesota Department of Health. And this work is being funded and conducted in collaboration with the Minnesota Department of Health. And so just a little bit of background on the Minnesota COVID-19 model and its origins. So it started in early or mid-March, when kind of, the epidemic was starting in the United States, and we'd seen some cities and various locations have some pretty large outbreaks. And we at the university, as people who model infectious diseases, were exploring opportunities for actually, typical university fashion, grant applications and funding opportunities to do some modeling for COVID-19 in the ways that we typically do. So looking again, as Sarah mentioned in my bio, mitigation strategies and how to inform policy decisions in light of all this uncertainty about the disease and what would happen. And so we reached out to the Minnesota Department of Health, actually just asking for a letter of support for a grant application. And they responded by, sure, but actually we'll put you in touch with our modeling team, and perhaps you can have a helpful conversation with them. And it turned out the modeling team was tasked with finding a model to use. And so they were delighted to find us, a group of people willing to make them a model tailored to their desires and to the state of Minnesota. So that's really how this came about. It wasn't necessarily you know, well-planned endeavor, as many things were in March, right? It was kind of a bit of chaos and people were reacting very quickly. So that's where it happened. And a lot of this work was done very, very quickly to try and get answers to decision makers and provide some intuition behind what this infectious disease might do in the state of Minnesota. And so this was really a very different way of operating than we as academics typically do. And Kumi and I have both worked on HIV and STI models on a much kind of slower time scale. So this was really a quite different experience, I think, for both of us. So with that, I will present this model. So the Minnesota COVID-19 model is a compartmental model that uses mathematical equations to represent the dynamics of the novel coronavirus transmission and these COVID-19 outcomes. And so I like to contrast this with a statistical model, where a statistical model is really trying to extrapolate observations into the future. And this model is really trying to represent the actual mechanisms by which the infectious disease is transmitted in a population, and the way that we get the COVID-19 outcomes like morbidity and mortality that we observe in our populations. And so I'll go through that in a little more detail. At a high level, right, the model stratifies the population by age because we found many outcomes differ by age. And we do stratify by the presence of underlying conditions, as this can also be important in determining COVID-19 outcomes. And these are all reflecting Minnesota demographics. And I do want to stress that revision of the model is ongoing. And we've had various versions and versions of versions throughout the process. So it's always an evolving project, as you know, our understanding changes, the questions that we want to ask change, and more data becomes available just as we've had more experience with this disease. So a mathematical model of infectious disease, and this isn't necessarily specific to only COVID, this would apply to many other diseases, is that we have a population that moves through different disease states. And in the case of COVID-19, what we're modeling is a susceptible, exposed, infected, recovered model. So people initially are susceptible, meaning they aren't infected, but they could become infected. If they become infected, then they move to the exposed state, where that's our kind of incubation period. So someone wouldn't test positive in this period, and they're also not infectious during this period, but the virus is starting to replicate. Then they would go into the infected or infectious compartment, this I compartment, and that's where spread can occur and where symptoms may occur as well. And then following infection, we're assuming that there's immunity that's conferred from the infection. So they go to this recovered state where they're immune to reinfection, at least for the time horizon that we modeled, right? And so we're learning more and more as, again, it's just we've had enough time to observe what happens to people who have been infected and how long their immunity lasts, right? So that's understanding is still evolving. So this rate of moving from susceptible to exposed is really the crux of the infectious disease model, because it's modeling how people get infected. And namely, that is through contact with infected individuals. And so the rate, the number of people moving from susceptible to exposed in any given time period is going to depend on the number of contacts that those susceptible individuals have, right? So how many people are they coming into contact with? So this large group of people here. And then the prevalence within that group of people. So if lots of these people are infected, the likelihood this person comes into contact with an infected individual is higher, whereas if the disease is still very rare in the population, the risk is lower. And then the probability of transmission per contact. So just because you come into contact with someone who's infected doesn't mean it's with certainty that there will be transmission, right? It's a risk. And so that probability of transmission per contact is important too. And again, in contrast to statistical models, these kind of mechanistic models where you're modeling this process of how many people are you coming into contact with, what's the prevalence in the population, what's the probability of transmission, that allows you to kind of play with interventions that influence these different factors, right? So early on, the main kind of tool that we had to use was contact reduction. That was closing schools, closing businesses, asking people to stay home, asking people to work from home, and to socially distance. And so that's reducing this number of contact that individuals were having in the population. The other thing that we can influence is the probability of transmission. As we learn more about the disease, right? Initially, there wasn't a mask recommendation. As we learned more about the disease, then masking became more of a policy, more at the forefront of policy. And now we're seeing more and more places have mask ordinances or requirements, either indoors or generally in public. And that's really getting at reducing that probability of transmission per contact, because the more that people are wearing masks, the less likely there is to be transmission. Okay, and so that's a difference here, that we can look at those influences on the disease dynamics, whereas in a statistical model, you're really just carrying out the curve, more or less assuming that things stay the same or making a lot of assumptions about how they would differ. Okay. So in addition to these susceptible, exposed, infected, and recovered compartments, we also have other outcomes that we're interested in the case of COVID-19. So a lot of the focus in this disease is about hospital capacity and overloading hospital capacity. So in addition to having this infected compartment, we also have some proportion of people who transition to needing hospital care and ventilator care within the hospital. And then, of course, there's a relatively high chance of mortality depending on someone's age and underlying conditions with this condition. So we also track COVID-19 deaths. But people who survive hospitalization then go to the recovered state, right? So they have that immunity from their infection. We also have a transition that is from the infected compartment directly to death, and this is reflecting the large proportion of deaths that actually occurred out of hospital in Minnesota early on. And this was largely due to people choosing to receive care, for example, in a long-term care facility, so opting not to transition to hospital, or for people who declined very quickly in their disease because, again, we were still understanding how best to manage it. And so weren't able to get to a hospital or get hospital care. And then we also added an asymptomatic infection compartment separate from the infectious one. And this is to reflect the fact that there are potentially a lot of people who have a very mild subclinical infection. So it's either you have no symptoms or you have very, very mild symptoms such that you don't notice them. So effectively, you're not maybe isolating the same way that someone has symptoms would. So the model was parameterized originally using data from China and then moving more to US sources, and we've kind of revised the data sources as more data has become available. And Kumi's really going to get into the details of this and how our understanding of some of these parameters changed over time. And I think that's just a really interesting kind of case study in what it means to be doing this kind of analysis for an evolving epidemic. We had age-specific hospitalization and ventilator needs and hospital mortality estimated from different sources. And so, again, this has changed. We had national sources and we had New York City data. And then I think we've also moved to now more Minnesota specific data, again, as we've had more experience with the disease in Minnesota itself. An important piece here in these models, so often in a mathematical model of disease, and especially in the case where you have a disease where not all of the kind of natural history is understood, calibration is an important piece of the model development process. And so this is where we adjust model parameters in order to match the observed outcomes thus far. In the case of COVID-19 in Minnesota, we were looking to match hospitalizations over time and the cumulative deaths that we had observed. And at the time where we were doing this and what I'm presenting today, this was kind of March through April. And of course, we've had more data since then, and so ongoing efforts are calibrating the model using this longer time series of data. And the parameters that we were adjusting were the proportion of infections that are asymptomatic or mild, because that really is something that's still very uncertain. How many infections are mild? You would have to do kind of really broad testing, routine testing, screening really of people to detect the proportion that are asymptomatic or mild out of the total number of infections. And then we also calibrated the contact reduction that occurred over the early social distancing measures that we had here in Minnesota at the end of March, and then the contact reduction that occurred under the stay-at-home order. And so just a note about that. So these were policies that were enacted, right? And so there were specifications on what was allowed and what was not allowed, right? So the schools were closing at the end of March, and then we had a more stringent stay-at-home order, which was closing more businesses, restaurants, and things like that. And then we had this reopening that occurred after mid-May. And so even though we know what the policies were on paper, it can be hard to relate that to what does it mean for the model parameters, namely that contact reduction. How much contact reduction does that achieve? Because certain individuals are still working. They're essential workers. There's grocery stores. And so there are things that need to continue, activity that needs to continue to happen. And so the exact contact reduction was unclear. People have also suggested that we should use mobility data. So there's like Google mobility, there's various cell phone data sets about how really movement has changed with these measures. And that can help identify maybe timing. When did people start kind of changing their movement patterns? But it still doesn't give us a quantitative measure of exactly how many fewer contacts individuals had under these different orders. So these were calibrated to match the observed outcomes. And one thing I'll note, sorry, just on this, we didn't calibrate to cases. And the reason for that is because there was so much change happening in who was getting tested, the accessibility of testing, who was being recommended for testing over this time period. And so that makes it difficult to understand what exactly a case means relative to the total number of infections, many of which never get tested or identified, either because they're mild or because early on in the epidemic, people with symptoms that didn't require hospitalization were being told to just stay home and isolate and assume that they had the infection rather than get tested because testing capacity wasn't sufficient to test everybody who may have had symptoms. And that's of course changed over time as we've increased our capacity. So I'm just going to show some illustrative results here that's really about gaining intuition about what different policies could do to the outcomes for Minnesota. And so here I'll plot some outcomes under, say, no mitigation if we had done nothing. Of course, we did not do nothing, so that's very much a counterfactual that we never lived through. And then various versions of kind of a stay-at-home order. So the stay-at-home order initially was proposed for 2 weeks, and then it was extended. So we'll show what we would have predicted for a stay-at-home order for 2 weeks, and then having ICU capacity expanded during that 2-week period. So under no mitigation, there's no preparation, there's no reaction. We just let the disease spread through the population. Under the stay-at-home order for 2 weeks, we use that time to expand ICU capacity so that at least there's higher capacity when infection starts to spread again. Then we also have a stay-at-home order plus distancing for the vulnerable. So this is what if we target a sustained contact reduction for those who are vulnerable. And in that model, we have people age 60 plus in that vulnerable group. And so that's kind of, they're going to be more protective, or we're going to put in measures to ensure that they can sustain contact reduction, even if the rest of society kind of resumes normal activity. And then we had, what if you extend that stay-at-home order from 2 weeks to 8 weeks, and along with that vulnerable distancing. Okay. So these are just a few different policies. And so here's kind of the intuition. So this is deaths, but a lot of the infections and hospitalizations follow similar patterns. Okay, so unmitigated, we see a very large peak that occurs very quickly, and then it declines over time. And this decline is due to herd immunity, right? So it's due to there being a sufficient number of people infected that the infection starts to slow. If we do the stay-at-home order, what we noted is that you get this reduction or this movement of the peak, right, to essentially a delayed peak. And it's slightly lower, but primarily, unlike that kind of the flattening that was promised in a lot of media coverage of stay-at-home orders, it's really about delaying the occurrence of disease, because as soon as you open up, there's very little immunity in the population, and so the disease is going to spread, and so you're going to get this large curve in deaths. Right? If we add on to the stay-at-home order sustained distancing for those most vulnerable to hospitalization and mortality risks, then we decrease this peak, but we don't substantially change it, because those individuals in our model, those 60 plus, aren't really the ones deriving infections, just because we had age-specific contact rates, and those who are older tend to have fewer numbers of contacts, even under normal conditions, right? They're not in big classrooms with individuals like kids are. They're not playing in large groups and things like that. And then if we further extend stay-at-home, again, we see the primary impact of stay-at-home is to delay the peak, right, rather than reduce it. So that was kind of one of our insights. And if we look at ICU demand, we're going to see the same pattern. One aspect that we like to stress when we're doing this work is that there's a lot of uncertainty. So prior, I was presenting a single curve as if like this is our predicted trajectory, but in fact, we had a lot of uncertainty, and there were a lot of different combinations of parameters that would even match hospitalizations and mortality data that would be observed in the state. And so what this kind of plot represents is the uncertainty. So these are all plausible kind of predictions of what might happen, with the red being kind of the baseline stay-at-home order for 2 weeks, and then the extended stay-at-home order and the vulnerable. And so you can see that there's quite a bit of uncertainty as to where exactly the peak would occur, right? This one's all the way out here, whereas this one's much earlier, and then also the height of the peak. So in terms of the insights that we can gain from this version of the model, it was really that social distancing primarily delays the epidemic peak and only modestly flattens demand for healthcare, and that extended social distancing among vulnerable populations is a good idea, because they are at the highest risk for these kind of healthcare needs and mortality risks. But again, as soon as you lift that distancing, then there's still going to be a substantial spread in those vulnerable populations. And so it really was that, stay-at-home orders are useful in delaying spread, but again, as soon as you're lifting, as soon as you're going to kind of back to quote unquote normal, then you're going to see substantial spread, right? And of course, we aren't necessarily going back to normal. And that's kind of getting at the next point, is the key was really social distance, or the stay-at-home order wasn't an intervention in of itself. It was really buying time in order to make changes. So these were things, maybe one of the first areas of focus was capacity expansion, right? Was it improving our healthcare system, having more ICU beds being available, increasing our testing capacity, increasing our capacity to do contact tracing, and all of that infrastructure work that takes time and planning to arrange. But I think equally as important is to also prepare for kind of what it means to reopen. So putting policies and infrastructure in place so that we can support sustained social distancing in the long haul, so that when we reopen, it's not that we're just reopening to what we did before, but to a risk mitigated kind of society. So this includes protections for the vulnerable population. That sustained social distancing that reduced the curve so substantially requires work. It requires policies. The vulnerable older adults who rely on others for errands and support at home and healthcare, they need to interact with other people. And so having a sustained contact reduction isn't a guarantee. And also, I think guidelines for businesses and workplaces and schools and all these places where we have a lot of activity and contact with each other, how to reopen those in ways that are safer, whether that's changing layouts, de-densifying places, or putting in modifications like plexiglass and things like that. And then of course, our mask policies. And then finally, delays allow us to take advantage of scientific knowledge. So the more we delay the kind of infection in the population, the more we can take advantage of improvements in clinical treatment, both availability of pharmaceutical treatments, but also just clinical management. How do we manage the course of this disease? What are the kind of risk factors that we need to look for to prevent these really catastrophic outcomes in those who are very sick? And then as well as just our gains in epidemiological understanding. So what is the best way to prevent these things? Which activities are higher risk versus lower risk? I think the role of being outdoors was something that really evolved in the epidemic, and in the early summer, it became kind of, I think, more clear that being outdoors was, had a great protective effect in terms of preventing transmission. So all of these things are things that we could take advantage of, but only if we had the time to do so. So with that, I'm going to hand it over to Kumin, and she's going to talk about our model parameterization journey.
Great, thanks, Eva. And thanks in advance for advancing slides for me.
Yeah.
Awesome. So nice to meet everyone. My contribution to this presentation is to just sort of add a little bit more, excuse me, detail to what Eva just presented by sharing with you a little bit of a story about the challenges of model parameterization for this model. So this slide is just to orient you back to what Eva was talking about earlier, where she was introducing the fact that her model diagram, which shows a bunch of boxes connected by arrows, is actually a series of equations in which each of those arrows correspond to a value, a parameter that dictates what we think we know about certain aspects of the natural disease or care seeking, or all these other things that dictate how this disease spreads and how it impacts us. So this is the model that you saw earlier. And if Eva, if you could advance it, this is one particular relationship that we'll kind of focus on to tell you an example of the challenges we faced in parameterization. And if you could advance, Eva, this is essentially kind of a honing in on the one particular relationship, which is how people move from an infectious state to a state in which they're still infectious, but now in need of hospitalization. And so recall that this arrow that connects the I box to the hospitalized box tells you about how people move from just being a case out in the community or at home to the point now where they need to be hospitalized. So that sort of proportion of folks who need that hospitalization and the speed at which they'll experience that need is dictated by this black arrow that goes from the I box to the H box. If you could advance, Eva. We do just want to point out that, as Eva pointed out, this is an age stratified model, which means that it's not actually just one arrow, but in fact, one arrow for each of the 9 age groups that we were modeling. And the reason why we divided into 9 arrows is not because we love to make more work for ourselves necessarily, but rather because we think that this relationship, the way that people move from an infectious state to a state where they need hospitalization, varies by age. And if we believe so, then we have to have a unique parameter for each of these 9 different age groups. So what we did, if you could advance, Eva, was to basically go out into the big wide world of literature that was being put out. And there's a huge volume of research being published every day into which we had to wade and to try to find information to help us. So recall, we're interested in those 9 arrows, or as many arrows as we have for our different age groups. And we're trying to understand, in this case, the proportion of people who are moving from that I state into the hospitalized state. So the first source that we considered was this early report from the Center for Disease Control, their famous Morbidity and Mortality Weekly Report. This report seemed perfect because, as you can see in this table that they published, it presented the proportion of all diagnosed cases at the time who were hospitalized. Those are shown in that first hospitalization column. It also showed us the number who were admitted to the ICU and those who died. If you could advance, please. And even more perfect was that this data was stratified by age, just like we needed. But if you could advance, what happened was that as we read more details about this paper and where the data came from, we found rather troubling information about just how many of these cases were missing data. So specifically, of the 4,226 cases that were analyzed in total for this report, 1,514 cases were missing information about hospitalization. That's about 36%. And that means that we have no idea if those cases ever were admitted to a hospital or not, or if they went into outer space. We have no idea. And the case was that it was even worse. This missingness was even worse for ICU admissions. That number there corresponds to about 53% of cases who are missing any information about ICU admission. And for death, that number corresponds to about 47%. So if you take a look at this, what the problem is that we can't even really use the information of the cases that are there because we don't know anything about the cases for whom we are missing data. And when you're missing as much as, over 20% is already quite problematic, but in these cases we have 50% or about half of cases who are missing any information. If that information comes back to us one way or the other, where most people were admitted or weren't admitted, it could really change our understanding of the epidemic and therefore what our model does. I will just quickly say that there has been a lot of talk about how disease surveillance and data collation is happening in the US, and for the call for it to become more centralized. And that's a very important and relevant conversation. But for the purposes of our modeling and for the parameterization goals, these data became unusable, at least for the time being. If you could advance, please. So after finding out these issues, we went on searching and we found an article that was fresh off the press. In fact, at the time that we cited this article, it was still in a preprint, which means it hasn't been through any peer review yet. It described data from a single hospital system in New York City. And recall that at this time, the epidemic in New York City was really hitting its first surge. And so there was a huge amount of data from this paper. And moreover, and more importantly, the data was far more complete. And again, it had data stratified by age as we need. You can see here that it was providing us the overall number of cases in that first column, those who did not go on to be admitted to the hospital in the second column, and then in the third column, those admitted to the hospital. So that was what we really tuned into. However, at this point, what gave us pause was the fact that recall what we're estimating here, which is the proportion of all symptomatic cases in the community who ultimately need to be hospitalized. And if you think of what that proportion is, it's essentially a fraction, right? So the denominator of the fraction is all symptomatic cases in a given community. So in the case of this paper, it's all symptomatic cases living in New York City during this time. And then the numerator will be the subset of those cases that end up needing hospitalization. And the numerator is usually not the source of problems for us because hospitalization is a pretty well-defined event. In the US, if you get hospitalized, there's a huge amount of documentation that tracks that, and we all know that that's happening. So we trust those numbers relatively well. But the more common problem is usually in the denominator, and in the field of epidemiology, we like to talk a lot about the denominator problem. If you could advance, please. So when we thought about this issue of the denominator, we checked the details, and sure enough, we found a cause for concern. So testing here is, I'll just read the first line quickly. So the text of the paper describing the details of who this sample is said, testing was performed on people presenting to the emergency department who are likely to be admitted with any symptom or sign, so on and so on. I will point out, if you've read this whole paper, then you would know that testing was happening for people presenting not just to any emergency department, but specifically to emergency departments at any of the multiple clinics and hospitals that make up the NYU Langone health system. So again, if we're thinking back to the denominator we're after, we want to know about the data of all symptomatic New Yorkers with COVID-19, or at least a representative subset of them. But as Eva was pointing out earlier, testing in the US has been really variable by region, and then variable over time as the messaging that we've all received has changed. So there's been times when people have been told, avoid testing unless you're symptomatic, or avoid testing because you don't want to overload the healthcare system that's already burdened with so many COVID cases. Or come seek testing only if you've been exposed. There's been a lot of really confusing messaging about testing. And so we wondered about how representative this subsample of people who were presenting to these emergency rooms would be. It's likely that these were either the worried well, those who had particularly severe disease. Perhaps they were those with underlying conditions and that they were very scared about what would happen to them if they tested positive. And all those things make this subset of patients potentially different from the true set of patients that we're trying to estimate, which is all cases with symptoms in New York City at the time. An added problem is that we want this subset, even if it's very small, to be as representative as possible. And another thing that we realized is that the new NYU Langone health system is a very fancy one, and it tends to cater to patients with private health insurance and those of higher socioeconomic status. And this is already problematic given what we know about the disproportionate impact of COVID by race and class. So all these things made it much harder for us to use this data directly. If you could advance the slide, please. So given what we knew, and given that that was the best information we had at the time, Eva came up with this actually really brilliant workaround to make use of whatever we had on hand. So if you think back to the fact that we're trying to estimate the way that people move from the I box to the H box. So again, from being in a symptomatic case to being in a symptomatic case who needs to be in the hospital. This is essentially the problem we're facing. We need to estimate a value that represents each of these 9 arrows. If you could advance, please. And so since what we had, the issue that we had when trying to estimate each of these arrows was with this denominator, we decided not to use this data directly, but instead focus on other aspects. So we went back to the US CDC data, that first table that I showed you, which was at least representative of more of the country. And we examined not the exact number that labels these arrows, but rather their relationship with each other. So the relationship of these arrows to all the other arrows. If you could advance, please. And more specifically, we were looking at their relationship to the oldest age group, those who are age 80 and older. If you could advance, please. And so this thinking was used to estimate the proportion of cases needing hospitalization for each group, but specifically relative to that same proportion in the 80-plus-year-olds. So in other words, whatever value we think is true of the 80-plus-year-olds, the same parameter for all the other age groups would be scaled to what it is for the 80-plus-year-olds based on the values in this table. So what we're preserving isn't the actual value next to each arrow, but rather the relationship of each arrow to that arrow in the blue boxes. So just as an example, if we felt really confident in knowing that in cases among 80-plus-year-olds, that about half of them are going to require hospitalization, then we can use that information to estimate what we think that proportion would be for everyone else. So example, if you move to the next age group down to the 70 to 79-year-olds, we have there a relative rate or a relative risk of 0.74. So if you multiply that 0.74 by the 50% hospitalization rate that we know among 80-year-olds, this would correspond to 38% of the 70 to 79-year-olds who need hospitalization. If you could advance one more, please. And then to get that one remaining arrow, this is the one that goes from the the infectious state among 80-year-olds to the hospitalized infectious states among 80-year-olds. This is then what we calibrated to what we observed was going on in this age group in Minnesota at the time. So this is where you kind of allow the model to take the information that we know from the literature and from everywhere else that has more information about the epidemic, but then still allow the model to really speak to the situation in Minnesota. For those who are curious, we were able to use the rest of that data coming out of New York, coming out of New York City, but we used it more to estimate the proportion of hospitalized patients who then went on to need intensive care, and then those who then progressed to death. Next slide, please. This model, it has many limitations and is still undergoing many refinements. There was a limited amount of data in Minnesota at the time the model was fit. That has been changing, and we have been getting more and more information coming out of the Minnesota epidemic. And it's unfortunate that our epidemic has progressed to the point where we have enough data to be fitting our model. However, this is helpful because when you're in a very early stage of an epidemic, you might hear the term noisy data a lot, and that just means very early on, there's a much larger role that chance will play in displaying the patterns that you'll see in the data. So you're not sure if the trends that you're seeing early on are really true patterns of spread, or if it's just chance because there's so few numbers. We are now at a stage in the Minnesota epidemic where we actually are able to get more use out of the existing data, and this has really changed the way that we have been parameterizing the model. It's worth pointing out too that all of the data that I just described, including the workaround, does not help us get around the problem, which is that US hospitalization data is incomplete. This includes the data out of New York City and the data reported by the CDC at the national level. And what this means is that many cases are still hospitalized at the time that we observe the data. And so we don't really know how those cases resolve. So if we say of these cases, this many are hospitalized, some portion of those may go on to be discharged and some portion may go on to die. If we don't know what happens to them ultimately, it really does skew what we think we're saying about those earlier proportions. Third, there are a lot of evidence and stories about outbreaks happening in special populations. These include places like long-term care facilities, nursing homes, also in meatpacking plants. We've heard of stories of folks in churches or choirs, and our model does not take this into special consideration. And part of that is because of the challenges of the extra data demands that you'll be required to satisfy if you include these groups as sort of subpopulations within your model. Doing so in the future could be informative if we think that that there are special precautions that we can take. So if the model is projecting a lot of outbreaks, severe outbreaks in these populations, rapid and decisive interventions in these populations could prevent primary spread among these folks. Moreover, if we think that these these kind of hotspots of rapid transmission or amplified transmission could then eventually spill over and become a source of infection that seeds new outbreaks in the rest of the population, that's another important consideration for us in terms of disease control. And as Eva has pointed out, revisions to this COVID model are ongoing. Data is coming out at the rate of, I don't know if I'm making this up, but I feel like it's coming out at the rate of, I've heard 1,000 new papers a day, peer reviewed and not. It's a massive load of information for us to keep up with and to do our best. In addition, different mitigation approaches are being discussed and tried, and this is partly because of the fact that we are moving into a new reality of now school will be beginning in certain places. Weather changes might change the mitigation strategies available to us, and there's different levels of willingness for folks to accept different interventions. All of these things inform the way that we try to use the model or construct the model to be useful to key decision makers. And so with that, We'd like to thank you all for your attention and your time. This is contact information for any of the folks on our modeling team, as well as some links both within our University of Minnesota SPH website, our School of Public Health website, as well as at the Minnesota Department of Health website with details about this model, including code for those of you who are interested. And so now, Eva and I would be happy to take any questions.
Thanks so much. We don't have any questions yet in our Q&A, but encourage all of our attendees to find that button on the bottom of their Zoom window and submit a question if you have one. I'll note that in the follow-up email that I'll send out tomorrow to all of our participants, I can include these links that Professor Smith and Professor Enns have shared and their contact information as well. One question, so it's likely we'll need to wear masks and distance for quite a while. Is this right? What can you tell us about those mitigation strategies into the future?
Eva,
Yeah,
shall I let you take that?
Well, I think, yeah, so there's some questions that are, do you need a model to tell you that, versus kind of the epidemiologist, right? You don't need a model for all questions. But yeah, I think going forward, given that we can't stay at home forever, right? And the early models that were showing these really low outcomes and it wasn't going to be that bad, really had the fine print was that, oh, by the way, you're staying home forever until we have a vaccine. So given that that isn't the reality, then yes, I think we want to be taking as much kind of mitigation measures as we can. And so wearing masks is one, relatively low cost measure that we can take. And again, to protect others from potential asymptomatic infections or pre-symptomatic infections, because a lot of the infectiousness we are now thinking occurs before symptoms emerge, which makes it a very challenging disease. So all the symptom screening based strategies kind of miss and can't prevent that initial few days of infectiousness before symptoms present. So symptom-based screening isn't enough. I think we know that now. And so, yeah, so masks, I think, you've seen people trying to space people out more, make it so that one-way hallways, one-way aisles at the grocery store, so that people are all moving and they're not facing each other and coming into contact, and doing things outside. And I think as the weather in Minnesota makes that more and more difficult, then I think we're going to have to maybe think more creatively about what it means to do things inside and how to do those more safely, or maybe not do them and make that calculation.
Great. So 2 questions that came in that I think might be kind of similar, or you can answer together. One is, can you tell how accurate your predictions are? And then the other, what have you observed when you match the model's projections to the actual numbers? So how is that working out?
Yeah, okay, so both, yeah, 2 different people, similar question.
Yeah.
So I think, the way that we intend this model to be used is really for insight rather than a prediction of what things look like going forward. And one of the problems of trying to predict something going forward is it relies on knowing how people are going to behave and making a prediction based on those assumptions. So all of these curves is not what happened in Minnesota. It never got that bad, none of them, right? And so over the summer, we didn't see this surge of cases that we would have, that we were predicting under the assumption that once the stay-at-home order was lifted, other than that vulnerable group, people were resuming normal levels of activity. And so that was maybe a pessimistic assumption to be beginning with, because people, one, are aware that this is happening. Some people are scared. We started to have more tools like masks, like doing things outside. It was also the outdoor season in Minnesota. So even If things had started in the summer, meaning that if the coronavirus had kind of been introduced to the US in the summer, and specifically Minnesota, we might have just not seen that much initially because we were just simply all outside. And as I said, I don't think we appreciated how much being outdoors would make a difference in this case. And so one example of that is with the unrest that was happening at the end of May and the protests and demonstrations that were occurring. There was a lot of concern that there would be large outbreaks tied to that. And that just isn't something that we've seen in this case, the case data, right? Like a model, you could make all kinds of assumptions about how many people did people come into contact at those events, and it was chaotic, and how much worse is it because you have irritants in the air and things like that, but some people were wearing masks. So you can make all kinds of assumptions and predict it, but ultimately you have to look to the data to see, did we actually see it? And the answer was no, we didn't really see a whole lot of cases tied to that. So I think it's tricky to, our goal isn't really to have accurate predictions, it's to provide some insight given the information we have right now. And tomorrow we're gonna have different information. So we're less concerned about did we get it right than did we provide some kind of useful takeaways. Not that this is how many cases you're gonna have in 2 weeks, but did we have some useful takeaways for decision makers?
Yeah, that maybe kind of leads into another question we've received. So Minnesota's daily stats seem to stay steady and low. Has Minnesota already peaked, and are we entering a safer time?
No. Like, did we have an initial peak yet? Like, if you look at if you plot the data, hospitalizations and things like that, like, yes, things have gone down, right? And so there is an initial peak. I think what's confusing is this idea of first waves and second waves and stuff like that. All of that is driven by behavior. If we stayed the course and we had a behavior before the pandemic and we refused to change and we did nothing, we would get a single peak because this would burn through the population, infect tons and tons of people all at once until we reach that herd immunity, right? That's the dynamics of an infectious disease. And that's what this model would predict. And what would vary would be with different parameters would be the height of the peak, how long it would take, and how many people, the kind of herd immunity level, right? And that's different for different infectious diseases. But all infectious diseases, this kind of models would have the same shape for all of them. So what's different is our behavior. And so we stayed home, we took preventive measures. As I said, we've moved activities outside. And so as we move into fall, some things are potentially going to change. Schools may start to move, and this varies by school district. Some schools are online, some schools are hybrid, right? And so schools are going to be resuming some kind of activity, potentially resulting in kids in a classroom together. And you can take mitigation measures, but none of this is with zero risk, right? So there's some risk. We've reopened bars and restaurants, and we've seen outbreaks linked to those. And so the extent to which we continue to engage in those kinds of activities and understand just what is really required to keep cases low is going to change. And then as we move inside, things are going to change. And as the weather gets colder, there may be a seasonality effect with I think we haven't seen necessarily the decline due to the weather with coronavirus. There's a question of will it have a seasonality like flu, but it certainly may be worse as we kind of have worse ventilation and are kind of, I don't know if we become more susceptible. That's maybe a biology question. I don't know, Kumi, if you have any thoughts on what to expect for fall. So yes, no, I don't think we're entering a safer time. And we also know that, I think the fundamental piece of evidence that I would be using to make that assertion is that we don't have substantial levels of infection, right? That we didn't have a very large peak, so very few of us have actually had coronavirus, so very few of us have immunity to it. And even if it's a vast underestimate, that even if it's 20%, that's still not enough to prevent widespread transmission.
That kind of points to another question we received. So different sources have estimated that the number of identified cases represent 5 to 10% of Minnesota's population. Do you have a feeling as to how that or what percentage has actually been affected?
You know, I think that is going to depend on the assumptions that we've seen thus far. And I wouldn't want to make an assertion right now just because over the summer things have been, you know, we've been matching the more recent data. So anything that I would think of would be from back in April or May. Yeah, it's something the model can sort of tell you something about, but it's going to be a wide range and be a lot of uncertainty in that estimate. But we're not at herd immunity.
Sure.
I think we know that.
Another question. A while ago, the administration, so I think the Trump administration, required hospitals and states to stop submitting COVID data to the CDC and instead submit the data to Health and Human Services. Can you talk a little bit about the impact of that change?
Sure. Kumi?
Sorry, Kumi, I think that I muted you.
Oh, am I audible?
Yes.
In full disclosure, I am not personally aware of that decision. I can only speak to what I do know about the struggles that the CDC has been having with the data. And as hopefully I made clear, there's a lot of limitations with the data coming out of the CDC. Some of you might know that folks at the New York Times actually submitted a Freedom of Information Act or a suit to get their hands on CDC data to look at, in that case, ethnic disparities, only to find that, like, you know, ethnicity is missing for tons and tons of cases. The critiques I've seen of the way that, not necessarily how CDC has handled it, but the way that our system currently works is that we passively, the CDC really can't mandate states to do anything. They can only submit recommendations and request to states to please submit data to them. So cases are being identified in all kinds of different clinical settings, in hospitals, at test sites. And then that's where you know, at the point of care is where workers and hospital workers are collecting data from each individual person that gets, you know, submitted and made into a case report form that then gets sent to the CDC. Note too that those forms and their completion is going to be pending on getting lab results back. And that's going to vary a lot by the testing capacity in each state. You might recall early in the epidemic that required states to send their samples physically to Atlanta to have it tested. So there were huge lags and delays at the time. And then also typically in a system like this, which is not unique to the US, you'll have workers, staff people at a health department like the CDC calling and checking in on individual case reports and, you know, asking after their completion and chasing down details. My guess is that one of the reasons that the administration requested that states start submitting their data through HHS, if that's what happened, was to try to ease the burden on CDC. And if that's the case, I hope it worked. I do think, though, that it's a small band-aid to the massive defunding of public health that's been happening over the past decade. And as we know, there's been massive efforts to try to hire people to do just the grunt work of a lot of what we're trying to do now, to feel our hands away around the shape of this elephant, which is to hire more contact tracing folks. There's just a lot of really routine, pretty boring work that has to happen in the same way over a long period of time in the same way for us to really understand how this works. And so I'm assuming that this might have been a small remedy to address that. But Eva, if you know anything more, feel free to correct me or add.
Yeah, well, so I think, you know, again, the challenge is stemming from the fact that this is a fragmented healthcare system. So not only do you have state by state policy variations, but also health system by health system, health record system by health record system. And so it's not a universal kind of system like some countries that can then pull data much more easily at a, you know, in Canada, like a provincial level, or in other countries at a national level. So that certainly makes it challenging and creates a lot of manual work, like Kumi's saying, or kind of workarounds to try and get this information in a standardized way to CDC. And then I think the move was perhaps intended to be a remedy to some of the issues that were happening at CDC, but I think perhaps a better approach would be to improve the CDC system rather than taking it out of CDC's jurisdiction. Also, CDC is for all of the challenges experienced in putting together these MMWR reports and presenting data at national levels based on reporting that is received to them, and HHS in a kind of public health service way and a way of briefing states, whereas HHS has less of that, at least public role. So I think there's something lost there by moving agencies completely. So I think it would have been better to strengthen CDC rather than completely jumping ship to a whole new system that clearly has flaws, right? There were lots of promised kind of bells and whistles of the system, that it would be real time and so on, and that has been woefully underdelivered.
Well, it is 1 o'clock, and I see some of our attendees are starting to hop off, probably people with other meetings and things, but wanted to say thank you again so much to Professor Enns and Professor Smith for joining us and sharing all of this information about their work. I will send a follow-up email to all of our attendees tomorrow with some of these links and information and contact information as well. So thank you again to you both for joining us.
Thanks so much.
Thanks for having us.
Have a great afternoon, everybody.
Bye all.